Good evening and welcome to the Immunodeficiency Foundation's last forum of 2022. Today's program will explore information on COVID-19, flu, and RSV with Dr. Paul Maglione. My name is Emma Martins and I'm the Program Manager of Community Health at IDF. On behalf of all of us at the Immunodeficiency Foundation, I'd like to thank you for joining us this evening. For over 40 years, the Immunodeficiency Foundation has served as the trusted organization in the PI community by providing accurate and timely information, resources, and support to those living with PI. A brief disclaimer before we get started. Please remember that information presented during this forum is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your PI journey. Whether you are an individual PI, a family member, a friend, or a healthcare provider, IDF is here to help. When you have a question about living with PI, health insurance, or more, simply go to the IDF website, click on Ask IDF, submit your question, and a staff member will follow up with you. For those seeking support or connection with others within the PI community, IDF also offers Get Connected groups and peer support. This meeting is made possible by our wonderful sponsors. It is due to their partnerships and contributions that we can provide programs such as this one to everyone in the PI community. Please join me in thanking our 2022 sponsors: CSL Behring, Grifols, Takeda, Horizon Therapeutics, Accredo, Octapharma, Farming Healthcare, ADMA Biologics, AstraZeneca, Bioproducts Laboratory, Kedrion Biopharma, Enzivant, X4 Pharmaceuticals, and Chiesi Global Rare Diseases. And now we will have our word from our sponsors, starting with Grifols. Welcome, Jack and Debbie.
Good evening, everyone. My name is Jack Gillen. Like Emma said, with Grifols, I'm delighted to be here tonight joining you on this forum. I'm a specialty rep in the Philadelphia area promoting Gamunex and Zembify, our sub-Q version for primary immune deficiency. I'll be very quick. You can see, I just wanted to mention both of our websites where you can get a lot of information about both products, but most importantly, financial assistance. As you can see, our Zembify and our Gamunex connections, which offer $10,000 a year annually for patients to help with any copay assistance. So I just wanted to keep it short and sweet tonight. Again, thanks for having me. And I hope everybody has a nice holiday season. I'm going to turn over to our nurse educator, Debbie Manning. Thanks again.
Thank you so much. As usual, the Immunodeficiency Foundation. And just quickly, I'm a nurse educator with Grifols. And just a quick little note, heading into the flu season, which I think we're already in the flu season actually, but just keep in mind that, COVID-19 is still circulating at medium to high levels in many areas of the United States. Because of the symptoms of COVID-19 and the flu are very similar, testing for one or both may be necessary to determine the appropriate treatment. So just always keep that in mind. Also, if you can, try to obtain the flu vaccine, and any of your family members or close contacts should also think about doing that to help protect you. And of course, always speak to your healthcare professional. And once again, everybody, please stay safe, have a healthy and happy new year. And thanks again, the Immunodeficiency Foundation, for inviting us.
Wonderful. Thank you so much, Jack and Debbie. All right, and now we will hear from our partners at Octapharma, and we have Joanna joining us. Welcome, Joanna.
Thanks, Emma. Hi, everybody. I'm Joanna Maltese. I'm a clinical nurse educator at Octapharma, and you can start my slides. At Octapharma, the patients that we serve with the products we manufacture are always at the top of our mind. Next slide, please. So we have designed a program called IG Cares to support specifically the PI community. We have designed the program to be a 360-degree support service for PI patients, whether you are on one of our products or not at all. So you'll find lots of educational resources about living with PI, peer support, a charitable giving initiative that supports charities like the IDF. Next slide, please. And then for patients who do take one of our drugs that we manufacture, like Qutoquig, our 16.5 subcutaneous therapy, we have a copay assistance program. We have an app to keep track of your infusions to help you stay on top of your therapy. And we also have more information available on the IG Cares program and on QutoQuigUSA.com. We're thrilled to support the IDF. We've been doing it for years, and we are happy to partner with you. So from all of us at Octapharma, enjoy your holidays. Please stay safe, and we will see you in the new year. Thank you.
Wonderful. Thank you, Joanna. All right, and now I am so pleased to introduce our presenter for this evening. Dr. Paul Maglione is an assistant professor of medicine at Boston University and provides clinical care to individuals with PI at the Boston Medical Center Primary Immunodeficiency Clinic. Welcome, Dr. Maglione.
Thank you. Thank you for the opportunity to speak. It's really my pleasure to talk about this and talk to this group at IDEA. So thank you very much. And I'm going to do my best to discuss what is a broad topic. So my goal here, my goal here is to give a good overview to make sure that everybody's up to speed with these topics. And then we have a question and answer session, which I will do my best to answer what questions remain after my presentation. One thing I always want to mention in these sorts of sessions is that the best guidance will be from your own personal physician that knows your that knows your case, that knows your condition the best. My comments will be really general, and I'll do my best to explain my reasoning and the things that you can use to apply to your own situation, but it doesn't replace the knowledge and the experience of your own physician. I just want to make that clear. Because obviously there may be some things that I say that aren't entirely applicable to your circumstance. So here we go. We're going to talk about COVID, flu, and RSV as we are now in the winter season, as my background highlights. So I'm going to talk about these topics today. This is going to be the agenda. So it's going to be what these viruses are, the symptoms, how they're transmitted, the preventive measures we have, if there's vaccines and other treatments. What those are, and then the role of IgG replacement potentially, and then how you differentiate these three if you can, and then the concept of the triple-demic and what that means and why it's kind of significant that all these things are sort of coming together, and they're coming together in this particular year. So we'll start with the topic that I think everyone is pretty knowledgeable about. But what is COVID? So COVID, or COVID-19, stands for the 2019 coronavirus disease, right? And it's caused by SARS-CoV-2. That's the virus that causes COVID, which is the disease. And the virus is a positive single-strand RNA virus. It's related to SARS-CoV-1, which caused the early 2000 SARS outbreak. As of just a few days ago, it's been estimated that there is about 650 million confirmed cases with a death toll over 6.5 million. That's our best guess, but of course it's only limited to who was doing testing, how these things were confirmed. But it really highlights the massive scale of this ongoing pandemic. So flu. So what is flu? So flu is a negative single-strand RNA virus. Notorious for its ability to alter its genome every year. This is why, we need a new vaccine every year, and it's one of the ways that it's really evaded long-term immunity, and a major characteristic of the virus. Historically, the CDC estimated, about 140 to 800,000 hospitalizations a year, tens of thousands of deaths annually for this virus. So it was, it's always been a very significant respiratory virus. And now, within the sort of environment that we're in this winter, it really comes to the forefront again. RSV. So this is something that we haven't always talked about, particularly in adult patients. Parents and pediatricians have thought about this virus a lot, but not always thought about with adult patients, and that's changed this year. Let me tell you a little bit about RSV. So RSV is this respiratory syncytial virus. It's a negative single-strand RNA virus. It's the most common cause of respiratory hospitalization in infants, but it's an important pathogen for all ages, in particular this year. It typically causes an inflammation of the bronchioles in children and infants. It can cause most typically a cold in adults, but more serious respiratory illnesses can occur in the elderly and the immune compromised. And that's a theme of all three of these viruses. In general, they don't always cause severe infections in everyone, but they can. And they can particularly cause severe infections in those that are older or immune compromised, as this audience is really well aware of. So this is why it's important to be aware of these viruses and be knowledgeable of them. But let's talk about the symptoms and maybe some of the symptoms. Well, the truth is a lot of the symptoms are going to be shared among these three viruses, and it's very, very challenging to differentiate them. Things like fever, chills, cough, shortness of breath, fatigue, muscle aches, headache. These are, typical of respiratory viruses. Runny nose, congestion, sore throat. Again, very typical of respiratory viruses. Historically, one of the symptoms that helped to kind of differentiate COVID was this loss of taste or smell. And that was something that was, I think, and the data has borne this out, it was more prevalent, more commonly occurring early on in the pandemic, and less so now. That might be because of the way the viruses have evolved. It might be because people now have a certain degree of immunity, and that limits this complication from occurring. Whatever the reason, that's less reliable, and it's not something that occurs quite as much as it did in the beginning. But if this does occur, loss of taste or smell, it does seem to be a little bit more suggestive of COVID. So what symptoms does the flu? What's the flu? What does influenza cause? Very, very similar. You're going to fever, runny nose, sore throat, myalgias, headache, cough, respiratory symptoms, malaise, most typical. Okay, so not a whole lot different than COVID. Some of the complications that we do encounter with flu that might be a little bit different, right, is this myositis is something that maybe comes up a little bit more commonly, and complications of the central nervous system maybe a little bit more commonly in flu, but overall, historically, we've been kind of concerned about bacterial superinfection, which basically influenza comes in and causes an infection, and then days to weeks later, you can then have a bacterial superinfection. Because basically what the virus has done is damage the lung in a way that makes it more susceptible to infection, suppress the immune system in a way that makes it more susceptible to infection. And now we're sort of living in this environment with three highly contagious respiratory viruses circulating together, that this idea of superinfection becomes even more relevant, not just for bacterial superinfection, but potentially superinfection with another virus. In most individuals, we get recovery. Again, this is general population will get recovery from influenza in 5 to 7 days, but the fatigue, malaise could even persist for weeks. So it could be quite serious in just about anyone, but in particularly those who are immune compromised, obviously, we think about. What about RSV? Because we, again, as I mentioned, maybe not talked about as much. And RSV, historically, again, severe infections in children is where we were most worried about it, causing inflammation of the small airways, pneumonia, particularly in children less than a year old, where it's the most common cause of hospitalization due to respiratory etiology. And then again, it's the elderly or the immune compromised, which historically we really considered those who had significant defects in their T cells. But the reality is that what's happened over the last couple of years is that exposure to RSV, which has been something that's usually on an annual basis, has been limited. And we'll talk about why that was. And so even in those who might have antibody deficiency, there might be less of the anti-RSV antibodies in the product because there's been less exposure to this virus over the last couple of years. So that's postulated. It's not shown, but I just highlighted it because we need to think about potentially susceptibility a little bit broader than historically what we thought about. But generally, healthy adults and children and infants do not need to be hospitalized. So that's a concept I think is important to explain to sort of family members or others who may not be immunocompromised and may think, well, okay, this virus is nothing. It's just, I'm not that sick. It doesn't mean someone else couldn't be very sick from the virus. It can, and that's a concept that I think people understand a bit more with COVID having, been so prevalent in our lives, but might need reminding in certain individuals in their life. The symptoms: runny nose, decreased appetite, coughing, sneezing, fever, wheezing. These are things not going to differentiate very much from the other two viruses we just introduced. So again, the concept is that this is a real challenge. And, there's testing, that's pretty easy to get a hold of for COVID. There is testing, a little less easy to get a hold of for flu. There is testing for RSV, but oftentimes it's limited to the inpatient setting. It might be harder to get a hold of. So the bottom line is it's often hard to know which virus you are infected with, and you may not know which one, and you may be infected by more than one. So that's another complication as well. Historically, almost all children had RSV by the age of 2. That's changed, and we'll sort of talk about why that is. But that's been a piece of this. And typically, you'll get symptoms within 4 to 6 days after being infected. So, one difference with COVID is it had that longer duration that you could be asymptomatic. You may not get symptoms for like 10 days. That's been a bit of sometimes a challenge in terms of knowing when to quarantine, knowing when to test. And that's what made it an even more difficult virus to contain with these conventional measures that we had in place. So how is SARS-CoV-2, the virus that causes COVID, how is it transmitted? So this is where I think there's some key differences that I want to highlight between the 3 viruses, because I think they're important to understand, and particularly when you're weighing your thoughts about how you want to approach the holiday season or just the winter season in general when there's more time indoors. It's important to understand how these viruses are transmitted. So SARS-CoV-2, the virus that causes COVID, we believe now, having dealt with this virus now for 2 years, that it spreads mainly through an airborne or an aerosol method. So the current evidence suggests that it's spreading mainly between people who are in close contact, conversational distance, and generally through small liquid particles when they're coughing, sneezing, speaking, breathing. That's a major way. It's not the only way, but that's we think probably the major way. Now it can also spread further in poorly ventilated or crowded indoor settings, because these aerosols might stay suspended in the air longer, travel farther. So they could be what we call long-range aerosol transmission. So there's a short-range transmission, which you probably think is the majority of transmission, then long-range, which is going to an indoor crowded place that has poor ventilation. You might actually have somebody from the other side, much farther away from you, ending up infecting you due to the circumstances there. Now, droplet transmission, which is something that we thought about in the very beginning, and people wiping down everything and being concerned about that. It probably does occur, but probably less so than these airborne transmissions. And this is when things get infected with touching your eyes or nose or touching contaminated surfaces. This is probably not the major mode. It's not to say it can't transmit this way, but it's probably more through the aerosol transmission. So take that example of SARS-CoV-2, and now let's talk about influenza in contrast to that. So influenza actually is sort of like transmits kind of both ways. It can transmit through this airborne small droplet transmission that can stay in the air longer, or it can transmit through droplets which are larger, which ends up direct contact, can be a major transmission. And it's pretty contagious. In studies of households, about 30% household transmission. So it can be quite contagious itself. So here, the surface contact is important to be concerned about. So, sometimes you hear people talking about, well, it's really with COVID, it's airborne. We don't have to worry about wiping stuff down as much anymore. There's definitely other viruses we're dealing with that are definitely transmitted in droplet precautions, and influenza is one of those. And so we have to be mindful still of these droplet precaution things that we did and maybe weren't doing so much, have to start doing again. The masks are relevant, right? When we talk about N95, KN95 masks, those are important for the small droplet nuclei, these small droplet airborne particles that are sort of the real major way that COVID is transmitted. That's why those well-fitting masks were so important there for reducing transmission, droplets can be more easily blocked with the typical surgical mask. And so that explains, I think, why our avoidance measures that we adopted over the last 2 years for COVID were so, frankly, devastating in terms of the influenza transmission. It cut influenza out because influenza doesn't only depend on the airborne, it also depends on the droplet precaution. So if you're washing your hands, using ethanol, wiping things down, and wearing a decent mask, you're going to stop transmission cold pretty well. And so influenza was, really stopped quite, dramatically. And likewise, RSV was also put in check pretty well. And RSV spreads via almost exclusively through droplet transmission. So here, you've got to be, wiping things down, cleaning things. If you've got a kid that's snotty and wiping everything and kissing the face, all these things, you can get RSV that way because it's really spread through these large droplets. And so, touching surfaces and that sort of thing. So clearly, you want to be thinking about that in droplet transmission for RSV. But again, this is sort of why we sort of had 2 years of not a lot of flu and RSV transmission, because these are droplet transmissions that are really shut down by the approaches that we were thinking. They're usually patients or people who have RSV usually contagious for 3 to 8 days. And they may be contagious a day or two before they start showing signs of illness. So that's a challenge. Someone could potentially spread it before they know they have it. Like infants or those who have weakened immune systems can shed the virus even longer. So on the order of weeks. So this is something to consider, especially with this audience. The other thing is RSV can survive for a long time on surfaces. So this is, again, highlights the point of how it really isn't there's differences in transmission, modes of transmission between these viruses that I think are key. And here, RSV can survive longer on surfaces than we think, than perhaps the other two viruses that I mentioned. And so we think about, snotty children touching things, wiping their nose on things. Potentially hours later, that surface could transmit RSV. So if you have young children, or people have young children, and you're concerned about exposures, you really want to discuss this and say, look, are you wiping things down? Are you taking care of things? Because RSV can be transmitted this way. So how do you prevent transmission? Okay, what do you do? So first and foremost, you avoid contact with sick people. And if you're sick, you stay home for the sake of others. So that's a key piece to it. Very straightforward. However, as I mentioned, some of these viruses may be transmitting even before someone is symptomatic. So what do you do about those other possibilities? Well, good hand hygiene, washing hands, do not touch face, especially nose, eyes, and mouth. This is important, okay? Even though maybe less so for COVID, very, very important for flu, very, very, very important for RSV. So don't forget about this intervention, a simple intervention that's important. Cleaning routinely, frequently touched objects and surfaces, doorknobs, keyboards, phones, all these things. You want to be able to make sure you're doing that to limit exposure to these viruses. If you're, at work, make sure your workplace has an adequate supply of these things: tissues, soap, paper towels, hand rubs, disposable wipes. These are things that are small inconveniences that can really make a big difference. And we talked about the idea about droplet transmission versus airborne transmission. Again, the N95, the KN95 masks are the best for aerosol transmission. This is why they were the best for preventing COVID. Surgical masks have better efficacy against droplet transmission, and so can be important if you're dealing with the viruses that are transmitted this way. So you basically try to wear the best mask you can in the circumstance. So what are the vaccines for COVID? So it's gotten a little complicated, right? I mean, it's good news that we have options. So I think everyone's familiar with Pfizer, Moderna. These are the messenger RNA vaccines. Now it's approved all the way down to age 6 months. So that's exciting. Johnson & Johnson has kind of gone out of favor. It's much more limited use because just frankly is an inferior vaccine. And you probably, unless you have a medical reason or contraindication to not get the others, this is one that you probably should move beyond. Novavax is new. There hasn't been so much in the news about it. It's a protein subunit vaccine. So it's a little bit more of the old school type. So perhaps for people who have had an aversion or concern about the messenger RNA technology, it's too new, I don't like that, they might be drawn to this Novavax vaccine. This is a protein subunit vaccine because it's more like the vaccines that people have gotten in the past. But the boosters, the bivalent boosters, remain the messenger RNA vaccines, because these are the vaccines that are most able to react and be made faster. You can quickly change the messenger RNA code, put a new protein in there, and get it into testing and into patients a lot faster. So that's the advantage of this technology. So the bivalent booster basically is meant to provide added protection against the Omicron subvariants. These are the ones that have most recently come out and are more contagious than previous variants. And it utilizes basically the bivalent booster is the BA4 and the BA5 subvariants that are pretty closely related to the original variant Omicron. And I'll get into a little bit more into the alphabet soup of COVID subvariants a little bit. But the idea is that it's trying to target something a little more recent than the old, original strain of COVID that the original vaccines were designed around, because this virus has changed so much, as we well know. Now, relevant to those who are immunocompromised, the recommended strategy is 3 primary series, so 3 primary doses, each dose at least 4 weeks apart, and then a bivalent booster at least 8 weeks since completing the primary series. And so basically, it's just getting an additional primary series dose. And again, this is a statement that is going to be not necessarily applicable to everyone in this Zoom, but overall, it's been very encouraging, the response to the vaccine in those who are even profoundly immunocompromised, that it has managed to derive antibody responses from patients that I don't think we would have expected it from. So I think the results of the vaccine, though not 100% obviously, and there may be certain individuals in this room where the vaccine didn't respond, and there are likely many where it did, and many who maybe didn't expect it to respond. And I think that's an encouraging piece of information for those in this IEF group to know that the vaccine does provide some degree of protection for many that maybe didn't expect it. The other piece that people do, and this is something to discuss with your individual doctor, is that sometimes you delay the COVID booster by 3 months if you've had COVID infection. This may depend on how immunocompromised you are and your individual circumstance, but that's something as well to consider. That is kind of a new thought process that has emerged. Let's talk about the other therapies for COVID. So here it is. In the news, the sort of doom and gloom kind of news that have been coming out is the idea that yes, the newest subvariants have come out, and they have been evolving to evade the monoclonal antibody therapies. And so Evusheld, which is a treatment that many of you have likely received, it's a combination of 2 monoclonal antibodies to prevent COVID. So it's not to treat COVID, it's actually to prevent COVID in those who are immune compromised. We typically give it after, at least 2 weeks after someone who's received the COVID vaccine. But when someone's on it, you can give a vaccine anytime. That's the recommendations. And basically, it's likely to be, this is one thing I want to stress, this is based on in vitro studies. So we don't necessarily know how that translates to in vivo and what that necessarily means. But there's data to suggest that it's likely ineffective against, some of the latest variants of COVID, including at this point, some of the strains like, BQ 1.1, BQ1, that are really emerged as some of the dominant strains based on the most recent data. So it's probably more than 2/3, maybe 3/4 of cases now are probably with strains that we think can evade Evusheld. And so at some point, I think in the not too distant future, we may decide to stop using it, much of the same way we've stopped using some of the other monoclonal antibodies, which I know can seem discouraging, but I hope at the end of this talk and in this session, I'll explain to you why that there is not a need to despair based on this result. But still, it does provide protection to probably about 1/4 of the variants in circulation. You don't always know what variant you have. So if you've been administered Evusheld and recently, not to say it's not going to do anything, we don't know. But there's a chance, ever increasing chance that the virus is going to evade it. So immunoglobulin replacement therapy. So this is something that at the very beginning of the pandemic wasn't really doing much. And I think with every passing month, as we move further and further through this, it's going to do more and more for you. COVID antibodies are going to come from the thousands of donors. We know everybody's pretty much gotten it now, and maybe gotten it more than once, and have gotten multiple variants of this. So there may be increasing benefit from this. we should acknowledge that. And the nice thing about this is in contrast to something like Evusheld, which is just 2 monoclonal antibodies that are easier for a virus to evade, what you're dealing with is thousands of donors and antibodies that are going to be targeting many, 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 many different aspects of the virus, much, much harder for the virus to evade. So this could emerge as something that's becoming more and more useful with time as something like Evusheld sort of fades into the distance. Paxlovid, which is an antiviral, and others that have come out, continue to maintain their efficacy because they work in a different way. You know, the virus can evolve to evade the immune system targeting it, but the fundamental biology of making the virus and the virus to function, that can't change, and so or doesn't change as quickly, and so the antivirals are still effective and are still available. You do want to start them soon. So you want to be able to start them soon. But the great thing is that testing for COVID is readily available. If you have symptoms, get tested and move and get this treatment as soon as possible. Because like I mentioned, it really needs to be started as soon as possible. There was historically, there was this intravenous drug, remdesivir, which was something that was used earlier in the pandemic before Paxlovid was available. It also similarly should start earlier. It's potentially a utility for younger children or like immunocompromised folks that might be in the hospital. This may be something that people consider, so be aware of it. So in general, the antivirals are still on the table and will probably become a bigger piece of the therapy of COVID. Okay. So what about flu? So we've got a couple of flavors of vaccines as well for flu. You've got the live attenuated, or you've got the dead inactivated virus. So the live nasal attenuated flu vaccine, typically we don't recommend for patients with immune deficiency because it's a live virus, so probably not going to get that one. There's the quadrivalent flu vaccine, which can protect against different flu viruses. Then there's a high dose vaccine, which has quadruple the antigen, or it has a stronger adjuvant to the vaccine. It's recommended for 65 years and older. I would have a discussion with your doctor about whether this is applicable for you, even if you're under the age of 65 because you're immune compromised. And I think personally, I think the concept is similar to the idea behind the COVID vaccine protocol for immunocompromised, where we give you that extra dose. We try to kind of hammer the immune system, wake up that immune system in a way that it may respond. And the idea would be the same with the high dose vaccine, is you kind of give a better dosage, a stronger activation, or a more adjuvanted vaccine. You give a stronger activation of the immune system, you might get a response from more individuals that maybe wouldn't have responded to the lower dose vaccine. I mean, that's the logic behind targeting 65 and older, because as you get older, your immune system gets a little less responsive. I believe the logic should be applied with immune compromised individuals even under the age of 65. This is not a live vaccine. I don't think the risks are particularly high here. I think the benefits potentially, strongly outweigh them, and it's worth a shot. So I would have that discussion with your doctor if you haven't already. Rest in fluids is a big, aspect of treating flu. And then there also is an antiviral for flu, Tamiflu. So the concept is similar to COVID. You want to react very, very quickly to this within the first 48 hours. Typically is best, but there might be benefit even beyond that. So again, I think it's important to try to get tested, at least for COVID and flu, because of these antivirals being available in the testing, being also available for these infections as well. What about the flu shot? Well, hopefully everyone who can get the flu shot has gotten the flu shot. We'd like to get it usually by the end of October. You don't want to get it too soon, because there's a possibility that you might have waning immunity later in the flu season. And you do need to get the flu shot every year, as you probably well know, for those of you who can get it. What about IgG replacement therapy and the flu? Well, so the general thought is that the antibodies against the current influenza strain that's circulating are generally not going to be present in the IgG replacement product at the time when you're going to need them. And so that's the idea. Well, we say generally we will recommend influenza vaccine, because even in those who have antibody deficiency, you might get a T-cell response to the vaccine. Or, as I mentioned, if you use maybe one of these more potent vaccines, maybe you'll get a little bit of antibody response as well. And that could give you some benefit, whereas the IgG replacement may not. Now, there is some potential benefit of the IgG replacement as it relates to flu. it may help prevent superinfection because it could be antibodies against, whatever will come in and cause superinfection, a bacteria or otherwise. And there may be cross-reactive antibodies in that preparation. This hasn't really been demonstrated, but I think if you extrapolate from the story of what's gone on, and I'll talk about this a bit with flu, is that there's been a pretty rough flu season this year, and it might have been in part there being a gap in immunity. So even though the strain changes every year, perhaps the antibodies from last year provide some protection. And now that we haven't gotten flu for a couple of years very much, well, maybe that's why the flu has been more severe. It's not the only possible explanation. I'll talk about some of the others, but so that might highlight that there may be some benefit that maybe we underappreciated until this year. So what about RSV? What do you do? So there is this typical symptomatic management with respiratory viral infections, and in addition to that, there is a monoclonal antibody that's been available for a long time to prevent severe RSV disease. So in contrast to COVID, where the monoclonals went out of efficacy pretty quickly, the one for RSV has stayed efficacious for quite a while. It just shows you the differences with viruses. It's usually limited to those who are severely immunocompromised or high-risk infants, and it's dosed during the RSV season. So it's always been sort of given for children, so that's historically where it's been. Ribavirin has been used to treat severe RSV. This is an antiviral medication. Again, like all the other antivirals, should be the sooner you initiate therapy is better. You want to really start it soon. And there is a product that is on the market that is enriched for anti-RSV antibodies and IgG replacement product. It actually remains, though, to be proven to provide enhanced protections against RSV. It's been approved just as a regular IgG replacement therapy, but conceptually, you could imagine that it might provide some added benefit, but that remains to be shown. It might be something worth having a discussion with your doctor about, but just mention it so you know that it's there. How do you differentiate flu versus RSV versus COVID? I mentioned some of the challenges. So I think I'm going to highlight, now that we've gone through everything, some of the key bullet points that we want to talk about. COVID, airborne transmission. Influenza, RSV, there's a larger component of droplet transmission. Influenza is kind of in the middle, airborne and droplet. RSV is probably almost exclusively droplet transmission. COVID, influenza, RSV can be quite serious, even though, or quite minimal. So that's the thing to remember. It's the same for all these viruses. So just because your brother, wasn't that sick with it, doesn't mean you're not going to get very sick with it. COVID can have this cause of loss of change in smell. That used to be a nice distinguishing feature of it. That's becoming less and less common, less and less useful. Flu tends to maybe come on the fastest. Symptoms within 4 days. RSV, right after that. COVID can take much longer. It can take up to a couple of weeks. And that's, again, as I mentioned, has been a real challenge in terms of limiting transmission of COVID, when somebody can walk around for nearly 2 weeks asymptomatic and carrying the virus. Really, really challenging. COVID appears to be contagious longer as well. So 10 days since the onset of symptoms maybe can be still contagious. So again, a challenge, and why people, when they test positive, probably should be masked for a fairly long time afterwards. So let's talk a little bit about triple-demic. I imagine some of the questions that we're going to get in the Q&A are going to be dealing with this. So what do we mean by this? So it's really, what we're going through is a winter season of which influenza and RSV and COVID are all going to be quite prevalent, and have, some of which have already been quite prevalent. So flu started off with the highest hospitalization rates for influenza in a decade. And this has been, a major, concern. And so why? So what's behind that? So one of the things I'll talk about is this, immunity gap. I'll get to that in a moment. But also, it's important to recognize that the strain that's out there is the influenza A, H3N2, actually is a fairly severe strain. It's caused actually double the hospitalizations over the past 6 flu seasons as H1N1, which actually caused the 2009 swine flu pandemic and got, in the news and all this. So it's, it's a fairly nasty strain of flu. So we should, be aware of that and be thinking about that. In the 2017 and 18 flu season, which was one of the worst, was worse for more than a decade, was actually also dominated by H3N2. So we've got a nasty strain of flu circulating. So what about RSV? there's actually record levels of RSV in 2022. The spike came earlier, October or November. It's usually late December to mid-February. It's affected older children more seriously. One of the reasons might be that there's been more RSVA this year, which is the more pathogenic form of RSV. So you've got a like flu, more dangerous strain in circulation. But then there's this concept that's kind of impossible to ignore, is the idea of an immunity gap. Is this contributing to why flu and RSV has been worse? So the idea is that these are viruses that people get exposed to, or the population gets exposed to typically every year. And that probably gives us immunity, perhaps short term, but some level of immunity that might dampen the severity in subsequent years. So if you go 2 years without people getting flu, without people getting RSV, because as I mentioned, the interventions we did for COVID were exquisitely effective for limiting flu and RSV, because these are much more driven by droplet transmission. And so you don't have a lot of flu, you don't have a lot of RSV, so you don't have a lot of immunity to these things. Now you're sort of now opening up everyone to go and be exposed to these viruses again. And what ends up happening is you don't have this immunity that you normally would have year to year. And you might have older children that haven't really seen much RSV because they've gone 2 years without having it. So that's how it ends up perhaps with older folks. Let's talk a little bit about COVID and these sort of variants that have emerged and have generated a lot of concern in the news and otherwise. So things like, the subvariants BQ1, BQ1.1, XBB, XBB 1.1 variants, they evade immunity, they evade antibody therapy, and that's raised the concern. But I'm going to say that they're derived. So we know that BQ1 and BQ1.1 are actually derived from BA5, which is contained in the bivalent booster. So while people look at the monoclonal antibodies and study them in isolation in vitro experiments, the reality is that we know that the booster, the data seems still to suggest that there's protection against severe infection. So there's still benefit out there. And I think when you have individuals that have broad range of diverse antibody responses, whether it's because they've had a combination of infection with COVID and vaccination, or even in individuals that have had IgG replacement therapy and can respond to the vaccine and so forth, that there may be protection, and I think there likely is protection in a way that should make you feel a bit better and having less despair about than sometimes is being covered in the news. So I really want to sort of emphasize that yes, we should be aware of the fact that our antibody therapies may be going away, but it doesn't mean we have no immunity. It doesn't mean we're back to square one. There is benefit of the bivalent booster. There is benefit of exposure to these viruses now, and for some individuals more than once. There's benefit likely from the IgG replacement products. We've got antivirals. We're not in the same place. We're not starting over. And we really do believe that these Scrabble variants, as we call them now, that have just gotten crazy with all these different letters and so forth, the vaccines still protect against severe infection. That is our best and our most confident answer for that. Does COVID or other infections cause immunity theft? So here's a concept that is relevant to the triple-demic, because the idea of immunity theft is, well, if you're infected with one virus, does that mean you're more susceptible to getting another virus, and perhaps even all three? And it's possible. There's a possibility that what can happen is a virus can make you susceptible potentially to another infection. As happens with flu when there's super infection. COVID, there's some evidence that SARS-CoV-2 might do this. It might sort of set the table for some of the other infections to come in. So we should be mindful of that. I can't say that it's a definitive concept. It's been proven. It's definitely happening, but I think we should definitely be mindful of this possibility and think about it. And it's important because I think some people are have the idea that, well, I'm infected with one, so now I'm good. I can go out there and I'm protected. I mean, no, you could definitely be infected by a subsequent virus. And in fact, there's a concept that's being put out there that your immune system is actually becoming made more susceptible to infection by one of the other infections. So that's another concept about how these three viruses could be coming together that we should be mindful of. And I think at this point, just about out of time. So I just want to end with one other concept. And I know in the Q&A, we will go through this in more detail. But I want to just go through my basic algorithm about gathering for the holidays. Because we're coming up to the holidays. People have probably already exercised some of these things for Thanksgiving. So this is probably not new, some of these concepts. But just so you know where I'm coming from, where my thought process is, how I'm going to probably answer questions that come out of the Q&A. I think one of the most important things you can do is have discussions with those you're going to be seeing. You want to try to get on the same page with the individuals that you're going to be visiting. If you decide to visit, the first question, obviously, are you comfortable with this idea? So let's assume you're entertaining this idea. You want to have conversations, if you can, with those you're going to see. You want to try to get on the same page. You really ought to plan around the highest risk person, which might be you. Sometimes that might be hard to convey to people, family members. Maybe you don't want to, you're embarrassed, you don't want to talk about that. It's also important to remember that the elderly are very at risk of all three of these viruses. And so it might be also helpful to just mention, Grandpa Joe, who is going to be here, let's do this and be mindful of this individual. Let's be mindful of someone else, in our family, that people might understand their susceptibility a bit better if you're having trouble discussing yours. But that's a real important thing to try to do. Now, that doesn't always happen successfully, but that's something that you want to try. Something else that comes up in part of these discussions is the idea of maybe a mini quarantine before the holiday. You want to spend about a week minimizing your interactions. This may not be possible for everyone, but if you can work from home, you try to work from home. If you can, limit going into crowded places, stores, these kinds of things, and asking family members and loved ones that you might see to do this, if they're willing to do this, able to do this, this can make a big difference, because this kind of gives you that period we talked about, that these viruses are going to show up, a lot of them, within a week, maybe a little longer with COVID, but things are going to show up during this period. So you try to have that, and then you can be testing during this period to really get a good idea of, okay, I think there's a good chance that this person, that, I don't have a virus, I'm not going to transmit a virus, or at least you can get test for COVID, that's available. You may not be able to test for RSV easily, but quarantining, testing, these are things that you could do to try to mitigate your risk. Masking. So this has become a harder and harder conversation to have with others. Sometimes what you can ask of others that are traveling, and you really want to see someone. There's people in this, as I mentioned, I'm speaking to a broad audience. There might be some people that are really trying to figure out, how do I gather? I want to gather with my family. What do we do? How do we employ masks? So you want to use the best mask you can. We talked about why, because airborne transmission with COVID in particular. Maybe someone's like, look, I'm not wearing a mask. I'm not wearing an N95, constantly. So how do you find, what can you discuss with? What can you talk about? Maybe they'd be open to targeted usage. Like, for example, when they're being transported to and from the event. Maybe they'd be willing to put it on during the most high risk moments, crowded situations. Maybe they'd be willing to wear it on an airplane for you. Maybe if they're not willing to wear it on the entire flight, maybe you can convince them, well, look, can you at least wear it when you're boarding and coming off the plane? Because that's when the plane is off. That's when the ventilation isn't on. That's when people are on top of each other. You're 2 inches away from someone else's face. Can you please put it on during that time? And if you're, on a window seat sitting next to someone else that doesn't have it, or the family member, you've got ventilation on. These are all discussions that come up to point one, having a discussion and trying to find something that can match your willingness to meet risk. But there are, maybe if you can give it, targeted usage, and can make a difference. Again, as I mentioned, sick people should stay home, even if COVID negative, because look, it doesn't mean you don't have flu, it doesn't mean you don't have RSV. And if we're talking about a loved one who's immunocompromised or elderly, they could be at significant risk. Get vaccinated. Vaccinations from COVID and flu are there. Use them, get them. It's really, really important and fundamental to this. Spacing and ventilation. This is something that we don't always talk about, but it sometimes can be the easiest thing to talk about, because it's not asking a lot of other people. It's not asking them to mask or do something to inconvenience them. It might be sort of the layout of the way people are sitting at a gathering, putting space between people. Can you ventilate the room? Are you someplace that's warm enough that you can have the windows open or even gather outside? That would be wonderful. But even not, can you run a fan? Can you do something that might help to disperse the air and ventilate the situation? Not having people sitting directly on top of each other. As we talked about, cleaning surfaces, doing these things that can limit the droplet transmission can be really important, particularly for something like RSV, which is quite resistant. It can stay on surfaces for a long time. But the main point to really emphasize is nothing's going to be certain. So this answer, should I gather for the holidays, is going to be different for everyone, you know, and maybe some people are ready for it, they're going to do it, and that's great. And I think if you can, you know, abide by some of these, you know, these concepts, they might help you. Some people may not be ready, they might be severely immunocompromised and they're not ready to do it, you know, but I just want to, you know, emphasize that, you know, that we do have to get on with our lives, and if there are ways that people can do it and find their balance, and maybe it just comes down to that first point, is having discussions and seeing what can you do that's comfortable for you. Can you get the people that you want to see and that are dear to you to get on board, and you know, that's why I think discussions, that's why the first thing that I really listed here. So anyway, I think I went over on time, so I just want to get to the questions. So thank you for your patience going through that. I hope it was helpful.
Thank you so much, Dr. Maglione. All right. All right, thank you so much for that wonderful presentation. That was great information. We are going to get into Q&A, but before we do, we're going to hear a few quick messages from some more of our partners before we get into Q&A. All right, we're going to play that one again because I was just told we didn't have sound. So we're going to do that one again.
For more than 100 years, we've turned innovative thinking into solutions. CSL's investment in innovation has helped to develop a robust pipeline of safe and effective medicines and improve existing ones so that we can bring patients meaningful innovations and advancements that make their lives better.
My name is Dana Flandhammer. At Takeda, I am the Director of IG Community Support. You might know the team I'm lucky enough to be a part of as the MyIG Source Patient Advocates. I know that throughout my journey as a mom of 4 children living with primary immunodeficiency, the IDF has been simply an invaluable resource to me. I hope you learn a ton, and if you need us, know that nobody should ever leave us alone.
All right, and thank you so much again to CSL Behring, Takeda, and ADMA Biologics for their support of tonight's forum. All right, so now we're going to get to everybody's favorite part, and I'm going to turn it over to Colleen Brock, IDF's Manager of Medical Programs, who is going to lead us through the Q&A. Welcome, Colleen.
Hello, hello. Thank you everybody for being here. and thank you for a wonderful presentation. So we will start with the questions, and I'm actually going to kind of do them a little bit in reverse, but we will get to as many as we possibly can. So we're going to start with RSV questions first, Dr. Maglione.
Sure.
Any news regarding future RSV vaccines for adults?
Well, I don't have anything. So I would say that RSV vaccines are under development and have been under development. I'm not personally aware of something like particularly close for adults, but certainly I think this year has changed our perspective perhaps more than any other about the importance of this virus in adults. So I can't say that I'm privy to something. Doesn't mean there isn't something, but I haven't heard of it. I'm very sorry to say, but
I haven't heard either. It would be a good thing though. What is the difference, if any, between RSV and croup?
Oh, so I guess what you can think about croup being sort of a manifestation of RSV. So it's like one of those things is, not all RSVs are croup, but all croups that we think are probably RSV, that kind of thing. Because basically, yeah, RSV can cause this, bronchiolitis in children, and that's really what you hear with the croup is this sort of, weak, loud respiratory sounds that can be quite concerning. But RSV doesn't always cause that, as we talked about with all these viruses. There's a spectrum of manifestations, but in particular in infants, this is something that we're very concerned about. And as I mentioned, RSV is a major cause of infants going to the hospital because of croup.
Can physicians test to see if children have had RSV?
Yes, there is an antibody test that can be ordered, that can be evaluated in the certain circumstances. And this is sometimes done to try to find out whether RSV is present or has been present. So it is available. Something to discuss with your doctor.
Does RSV pose any special risk to people who have CVID and their T cells work, but they have bronchiectasis?
So I think in general, having a history of chronic lung disease does put you at concern for any respiratory virus. So I would say for sure, history of bronchiectasis, RSV could be problematic. However, I think that's probably the case for everything. You've probably been dealing with this and living with this for a while, and we know a lot about how RSV is transmitted, and so there are precautions you can take to try to limit exposure to it.
So now we're going to move on to flu questions. Some people are saying that this year's flu shot gives some additional crossover protection against coronavirus. Is there any truth to that?
Interesting. I don't know. I haven't actually. I couldn't explain why that would be. But I do think that, as we talked about, there's a bit of a domino effect in terms of, be able to have multiple, potentially one virus laying the table for the next virus. And so if you're protected better from one virus, I could imagine you might end up being better protected against another one because you're less likely to have this sort of domino effect of infections. So that's how I would link the two. I don't know if there's a specific aspect of the vaccine that's, has to do with COVID, but I could be wrong. I haven't heard that. It's an interesting idea.
How long after one develops symptoms can you test positive for the flu?
So the flu test is measuring a protein, and so that could be present for days after you've had symptoms, even potentially after the virus has been is gone. So then there's a PCR test, and then for a PCR test, which is a lot of times hospitals are doing these respiratory panels in our PCR tests for several respiratory viruses. In that case, you're dependent on the presence of nucleic acids that are present there. Again, that could be several days after the onset of symptoms.
This person is over 65 well, they had the over 65 flu shot, and it
Okay.
caused lichen planus rash and sores. They then had the flu block quad, which is 3 times more of the antigen than a regular flu shot. They had a much
Right.
more intense reaction with neurological symptoms.
Okay.
They then had now to go back to just the plain regular flu shot.
Okay.
Does an increased amount of antigen overstimulate the immune system in some people, causing these reactions?
Yes. I mean, I think it's something to consider, and that's why when I mentioned that, it's something to discuss with your doctor because it's not a one-size-fits-all approach. It's an idea that you should make sure your doctor is considered. But for sure, what it does is it really gives your immune system a real jolt, and it may not be the most appropriate vaccine for everyone, in this session for that reason.
Thank you. Now we're going to start with some general questions. What is the impact of all 3 of these for people who have no B cells or T cells and are on immunosuppressant medications? This person has good syndrome.
Yeah. Well, what I would say in general, I know it's hard to answer in a way that can be completely satisfying, but this has been your diagnosis and you face this challenge, and you've been you know, being with this before. So what this tells you, we're going through a period where there's, several viruses transmitting, and we're spending more time indoors, and we understand how that's particularly, relevant to the transmission of these viruses. And so someone like that may still need to maintain a level of vigilance that is more so than many other people. That's just a fact of life, and it's probably been that fact of life for you even before all of this, because that immune compromise has been there. So I just think it's part of what I mentioned, when I talked about, the holiday season. It's just, these are discussions to have with people and loved ones. Then people understand what you're going through and what your circumstance is. When things opened up, the decision wasn't made on behalf of the immunocompromised, as everyone well knows. The decision was made for the majority. And so these decisions don't necessarily apply to everyone here. That's why I mentioned there's some people in this conference that are more immunocompromised than others, and they have to continue to think about these things. But as encouragement, I would say that this is what you've had, and you've done a great job so far. You will continue to do a great job, dealing with this.
This is a very interesting question. As the mRNA vaccines seem to be working for immunocompromised people, is it likely that other vaccines, not COVID related, will be reformulated using mRNA technology so they will be more effective for the PI community?
That's a really interesting point, because I would say that comes down, I think, to dollars and cents, right? Because the companies have to decide, do we make this vaccine? Who they have in mind? Now, the good news is that I think this technology is so efficient, and flexible, and can be made so quickly that it benefits a broader group of people. And so the secondary benefit may be the immunocompromised community. But I'm not sure that will be the primary reason behind why these companies will do it, in my opinion. But who knows? But I do think it's the same rationale why I was mentioning with the flu vaccine, thinking about the ones that are targeting the 65 and older, for that same idea that there are certain grades of vaccination, and maybe one that's a little bit more potent might be applicable. But as one of the Q&A questions that had already raised, this is a discussion to have with a doctor that knows you well and knows your condition, because you could have potentially complications as well. So you want to make sure that you're thinking about your individual case. But I think that's an interesting point. I hope so. But I think whether or not it's specifically for PI patients, I think it's going to happen because this technology is now being applied more and more.
I agree. So let's move on to some CVID questions and COVID. When having CVID, is it important or better not to get vaccinated? This person never got COVID and they still don't want to be vaccinated. So if you have CVID, is it better to get vaccinated or take your chances and not?
I mean, my general recommendation is it's better to be vaccinated. I really believe that. Unless you have a medical contraindication, that you should not be vaccinated. I think the benefit is there. The reason is just like the prior question. There is evidence that many patients who are immunocompromised have responded to the messenger RNA vaccine. We have a vaccination series strategy aimed at targeting immunocompromised and waking up that immune system in those individuals. There's likely to be some benefit, and I think it's a good idea. So that's the way I'm gonna, that's where I'm gonna fall on that issue.
If you have been given the bivalent booster and you have PI, should you get another one?
If you've had the bivalent booster, should you get another one? Well, as of right now, there isn't a recommendation to do that. So we are not doing that. I'm not personally doing that. So I'm waiting, until these are things that are decided. But basically, the bivalent booster we think was given close enough to this season of respiratory virus season that it's unnecessary to do another boost. That's the thinking anyway.
Thank you. Can you review the timing for boosters, Evusheld, and IVIG or your sub-Q treatment?
Yeah. So, right. So the general rules are that we like to wait that 2 weeks from getting 2 weeks from getting the vaccine to getting Evusheld. So you want to get the vaccine and wait two weeks. But once you're on Evusheld, we think it's okay to become vaccinated at any point. And likewise with the IgG replacement therapy. Now I'll talk about my own practice, what I try to do. What I try to do with my patients is, because basically Evusheld and the booster have been around a 6-month timeline, like close, 4, 5, 6 months, they're kind of close to the length of time. So what I generally try to do is give the booster first, because let me explain what the conceptual concern is. The idea is that if you have antibodies in the Evusheld or you have antibodies in the IgG replacement therapy that are anti-COVID, they could intercept the vaccine and limit its efficacy. So that's the idea. That's the concept that people are concerned about, that the vaccine won't work as well because you'll have all these other antibodies blocking it. So if you get the vaccine first, then you wait for 2 weeks, and then you get Evusheld. That's why people like doing it that way. The IgG replacement therapy, it's really hard to time it. That's why we tend not to worry about it too much. But if you really want to be, you're the type of person that's really, trying to do everything precision, the idea would be to wait until close to your trough. So if you're getting intravenous replacement, you go close to your trough, which means right before your next infusion, and you try to get your booster then, so that you have the least amount of potentially COVID antibodies in circulation. And I mentioned this as a conceptual idea. It's not been proven. This is not something that we're basing medical recommendations on, but this is what the idea people have. And so if you're getting subcutaneous IgG, that's pretty level. It's not really changing a whole lot, and that's why I think people are feeling like, well, I'm just going to get boosted whenever during my cycle, because that's probably fine.
Are home COVID tests accurate for people with PI?
I would say yes. Yes, they are accurate. Like any the home COVID tests aren't perfect, and they're not perfect for anyone. There could be, sometimes sampling challenges, but I think they remain useful for any individual. There's no reason to say they're not going to be useful for someone with immunodeficiency.
We have a lot of medication questions related to COVID.
Okay.
So regarding Paxlovid, is there another option like Paxlovid that you can take if you cannot take Paxlovid?
Yes, there are other antivirals on the market. So you should speak to your doctor. There are now 2 others, and then there's the intravenous remdesivir, which had been used even before Paxlovid came on the market for people if they're unable to tolerate oral medication for some reason. There's that option as well.
And that was a question I was just getting ready to ask you. If you cannot take oral medications, what is your option?
Yeah, so that would be that would be the one to give there. So yeah, so I would speak to your doctor and kind of have a plan. If I get COVID, can I come in? Can I get remdesivir? Do you have a system in place to do this? Just make sure you're kind of prepared, because it's something you want to give within that first week of symptoms. So you want to sooner the better.
Is there any way that Paxlovid can be taken other than swallowed whole? This person cannot take large pills. Can you break it in half?
You know what? I'm going to be honest. I don't see why that would be a problem, but I don't know with certainty. So I would probably speak to a pharmacist about this and ask. Conceptually, to me, I don't see why that would be an issue. Like breaking, using a pill cutter is not an uncommon thing that people do, and doesn't impair the efficacy of the drug historically. But you might want to confirm it, because I'm feeling like I'm kind of making up the answer a little bit, but I don't believe that it would be affected. I can't see in my mind how it would be. And like I said, there are pill cutters, people cut pills, and it doesn't impair their efficacy.
So this poor person has had all the COVID shots except the bivalent booster and tested positive for COVID today. How does Paxlovid compare with sotrovimab infusions?
Okay, yeah. So you I mean, basically what you want to do is Paxlovid is going to be the best option there. Because basically that's the one that you want to start soonest. It's not an infusion, and it's really the best option in terms of in terms of an antiviral at this point.
Monoclonal antibody question.
Okay.
Do you know of any new prophylactic monoclonal antibodies that are being developed? If so, when might they be developed? And there've been a lot of questions about Evusheld 2.0. Is there going to be a new?
Yes. So I don't know the timeline of these things. They're very, I'm not privy to these conversations, but I know AstraZeneca, the company that made Evusheld, is making, Evusheld 2.0. They're working on this. I know Regeneron, which was, one of the first companies that made a monoclonal for COVID, one of the first that went by the wayside too, is, we're making another one. These things they haven't given up on this technology. They're coming back. It's just a process of, drug development is a slow process. And, so these things will come, and hopefully in a timely fashion, but I just don't know what that timeline is going to be.
If somebody takes Paxlovid and it's not working, can you follow up with remdesivir?
Well, I guess so. They work, they're different antivirals. I don't see why not, but these are something that I would definitely discuss with their doctor. This is not something that I'm necessarily recommending if someone's, considering this. But I mean, remdesivir is an IV antiviral, so that's something that you're gonna have to get a doctor to prescribe anyway. So you're gonna have to have a good conversation as to why you get it in that circumstance. But I mean, yeah, potentially could be considered, I guess.
Going back to Evusheld, if Evusheld is not working as well and they're due for their 6-month follow-up shot, should they still get it, or should they wait for a newer version to come on the market?
Yeah, so this is a tough question to answer. My personal feeling, this is me individually as a physician, what I've been recommending my patients is, as I mentioned, I have been recommending to give it until the FDA says no more, which because the FDA has done this for virtually every other monoclonal antibody that's came out. Like they basically tell you when the time's up, and there's going to be a point where they're going to say that for Evusheld, but they haven't yet. So I think I would say yes, because as I mentioned, yes, it is true the circulating variants that evade Evusheld in vitro studies are becoming, a majority of the variants in circulation in the U.S. But a couple of caveats to that: these studies were done in vitro, and they're done in isolation, right? With Evusheld, not Evusheld plus someone who's on IVIG plus someone who's gotten COVID antibodies. So maybe you're talking about tag teaming all these antibodies together. Maybe there's some benefit there, And I don't know for sure, but I'm saying I don't know what the harm is. I'm thinking, we've got to do everything we can to protect our immunocompromised patients. So why the heck not? Like throw everything in the kitchen sink at it as long as you've got it. That's how I feel.
I have another Paxlovid question that has popped up. Can one take Paxlovid with tacrolimus?
Yes, I don't believe there's any difference. Now, the only thing to consider is that there's renal dosing considerations for Paxlovid. So the question is, well, why are you on tacrolimus? Do you have, kidney disease? What will be the indication? How is your kidney function as you're on tacrolimus? So this is just a discussion to have with your doctor, but I would say the answer most likely is yes, given some caveats.
Thanks. Some other questions. Will 2 doses of Novavax help against the current variants? I'm allergic to the mRNA, and the booster for Novavax isn't allowed for 6 months.
Right. So I think yes. And the reason why I think this is that there is good evidence that even the older vaccines provide some protection against severe versions of the current Omicron, alphabet soup strains that we're dealing with. So I think it's like the same point about Evusheld. It's better than nothing. I mean, you got to do what you can. If you can't tolerate the other vaccine, but you can tolerate the protein conjugate vaccine, we'll give it a shot because, it's going to give you some benefit. That's better than none.
If you have the bivalent vaccine, should you have testing to see if you have made antibodies to it?
So the general recommendation is it's not necessary, because people don't quite know what the number means. Now, I have tested it in patients because I don't know, I kind of wanted to know that information because for me, greater than 0 meant something. Because some of you guys are 0 antibody people, and so all of a sudden you make greater than 0. Well, that's interesting, and that means something. But as long as you can interpret that data, it doesn't mean like I'm going to have, I'm throwing all the masks into the bonfire and we're good to go. As long as you realize that we don't exactly know what that number means, but I don't know. I think in some cases I have felt like it's been useful. And so it's something to discuss with your doctor. But generally speaking, we don't send it because we don't really know what to do with the number.
What is the chance that a person can get COVID once and then get it again and again and again with all these different variants?
It can happen. I don't know what else to say. It can happen. But you know what? This used to happen it happens with the cold. This happens with the flu. It happens with a lot of respiratory viruses. But what we're learning is that you do, because this is what this whole immunity gap may be telling us now that people having super severe flu and super severe RSV is that, you are getting more protection. Yes, you can still be infected, but probably not as severe with these subsequent infections, those who have intact immunity, obviously. But so I think the answer unfortunately is yes, but maybe it's not all doom and gloom because you're probably not going to get a severe infection, we hope.
Are people with PI more susceptible to long haul COVID? And does this ever resolve in people with hypogam?
So that might be the case. I think I've seen some data suggesting this could be the case, but we're waiting for it to be fully peer reviewed from what I've seen. So it's possible. I mean, look, I don't always, I feel like, the answer is, will it ever, clear? I mean, I think yes, I feel like it may be longer for some people. It may require different strategies, and certain individuals certainly can persist longer and immunocompromised. You can shed virus longer. But I think this is not something that's hopeless, not something that should be just, filling you with despair. I mean, these things can be cleared, and we're learning more and more about, the long courses of COVID and how to deal with that. So I would say that it's not acceptable to just, just say, look, this is the way it's going to be. I think there's still a proactive approach that needs to be taken in those circumstances. There's a
I will
reason
chime
they
in with
What, I'm sorry?
Sorry. I will
No.
chime in with, I sat in on a meeting today about long COVID. And the NIH is currently doing a study with 10,000 people. And they're not necessarily the immunocompromised community, but they are learning a lot. And one of the things that they talked about was there's not one specific cause. They think it's going to be multiple different causes, which may cause the multiple different symptoms that people have with long COVID. So it was very interesting. A lot is yet to be learned, but they are doing a massive study in a variety of ways. So they're looking at the patient, they're looking at their lifestyle, they're doing a whole bunch of different studies within those 10,000 people. So I think we're going to learn a lot in the future. So I have CVID and Wegener's and was recently exposed to COVID. So far, I've tested negative, but wondering if there's anything available for my exposure.
I mean, just the things we talked about, all the things you've done, and you probably have been doing. There's nothing additional, at this point, there's really nothing else you would do. Just be, vigilant, and if you have symptoms, talk to your doctor, get yourself, Paxlovid or some other antiviral, and get on top of it as soon as possible.
There's a question about the Novavax. Is that a live vaccine? This person's immunologist told him not to get it, and they're assuming it's because it's live.
No, it's not a live vaccine. It's a protein subunit vaccine. It may be because it hasn't been well studied in the immunocompromised population. I mean, and it may not induce a strong immunity as the messenger RNA vaccines. We talked about this. Messenger RNA vaccines are pretty good and done pretty well immunocompromised. So that might have been the reason to say, hey, we know a heck of a lot more about the messenger RNA vaccine. But as the question came up, previous, it's like, okay, well, is it better than nothing? Well, I say yes. I think if you're not able to get the messenger RNA vaccine, well, we got something else on the market. There you go. So I think that's my guess is that's where where it's coming from. It's like, well, if you can get the messenger RNA vaccine, that's probably the one you should get. But know that there's an alternative out there for those who can't get it.
So there's a couple IG therapy questions. One of them being, what is the difference between IG replacement therapy and convalescent plasma?
Oh, okay. So IgG replacement therapy is the product that those of you who are on, IVIG or subcutaneous IgG are getting, and it's pooled from plasma from thousands of donors, and not necessarily enriched for anything in particular. Although, as I mentioned, there's that one product that's enriched for anti-RSV antibody. Okay. Then, so what's convalescent plasma? Convalescent plasma is plasma derived from individuals who have recovered from COVID. Or we're talking about COVID convalescent plasma. It might be something else, depending on what you want. But the idea is it's precisely plasma from those who have had the infection that you're trying to treat. So they tried this. They did some studies with this very early on in the COVID pandemic because, well, we didn't have a whole lot of other treatments available. And so that's where the idea came. And in general, the results were mixed. So it hasn't really caught on like as a major therapy, but it's still available in some places and worth considering, I think, and having discussions about. But yeah, hopefully that explained the difference.
Thanks. Generally, do people with PI who are on IG replacement therapy need to get the new Prevnar vaccine for pneumonia prevention?
That's a good question. Historically, we haven't really worried so much about the pneumococcal vaccine in those on IgG replacement because they're getting the antibodies and it usually covers most of the serotypes. But the new vaccine does cover more. I think it's not a live vaccine, so perhaps it's worth having a discussion with your doctor about. Generally speaking, I'm not as concerned about it. The vaccines that I generally try to discuss would be obviously COVID, would be flu, as we talked about, because the strains change every year, And I'm kind of interested in the shingles vaccine oftentimes because it kind of gives you a boost of their T cell response that might be important to keeping the virus, dormant in their, is now a non-live shingles vaccine that works quite well. So those are the ones that I usually discuss most with my patients who are on IG replacement therapy. But I mean, anyone is worth discussing, provided it's not a live vaccine. I think it's fair that if you want to discuss it with the doctor.
Thank you. I'm wondering if antibodies from vaccinated plasma donors that are in our infusions can cause an autoimmune flare.
So this is a really important, an interesting topic because, by the way, there are autoantibodies in IVIG. This is a known thing. People can end up with positive ANAs. They can end up with positive autoantibodies. So this is why sometimes they can end up with antibodies against infections they don't have. This is why you always, when people are evaluating you and using antibody-based tests to evaluate you, they need to know you're on IG replacement and understand what that means, because you can end up with a positive hepatitis antibody. It doesn't mean you have hepatitis. It means you have antibodies against hepatitis. And likewise, if you have a positive ANA, it doesn't mean you have lupus. It might just mean you have some ANA antibodies. So the same thing could be said about any aspect, whether or not there's COVID antibodies or not. Typically, it doesn't cause the autoimmune disease, even if the autoantibodies are present, because there's a variety of factors that need to be present there to cause autoimmune disease, and more than just the antibody being present. So that's my best answer to that we've known autoantibodies being in the product even before COVID, and we don't generally think it causes autoimmune disease. But again, this is a lecture of, to zebras. Everyone may have, different, might be those cases of, 1 in a million where something happens. So, but generally speaking, that's not what we think happens.
We all can have different stripes.
Yeah, exactly. So I'm almost,
This question sums up quite a few that I've gotten. COVID antibodies in the IG supply. Since the time from collection to IG shipment is so long, wouldn't the old out of circulation variant antibodies that the IG contain offer limited protection now against the variants that are circulating, just like the vaccines that lose their protective ability as the variants have evolved?
That's true. But just like the vaccines, we believe that the antibodies could still protect against severe infection, provide some degree of protection. And that's what we are, interested in and excited about, that's probably still there. So I, don't want to be, I encourage you not to be overly discouraged by that aspect of what's going on.
Thank you. Here's one from about Israel working on a nasal spray that would coat the nasal and throat and kill the virus before a person could get ill. Do you know if the US is studying this? Are there any other nasal sprays that might come about? And does using a mouthwash help kill the virus?
Interesting. So all interesting points. I'm not fully aware of something analogous going on in the US. It doesn't mean it's not happening. I know there's a lot of general interest in mucosal vaccination, how that might improve the vaccine. For example, a vaccine that might be administered intranasally as opposed to intramuscularly. The rationale being that perhaps one of the reasons why the vaccines are limited to protection against severe infection and not transmission is because there's not enough mucosal antibodies being induced. And those are what plays the role in kind of preventing the virus from binding and invading the airways. So I know there's a lot of effort and research in that direction. That's encouraging, and there may eventually be a generation of vaccines that are aimed in that way. Much of the same, the model that's analogous, I think, is polio, right? There's an oral polio vaccine and there's an intramuscular polio vaccine. And the oral polio vaccine is fantastic at preventing polio transmission. The problem with the oral polio vaccine is it can revert to actual polio and cause polio. So it's not a safe vaccine to use in places that don't have high rates of polio. So what do we do in the US? We give the intramuscular inactivated polio, which actually doesn't provide as much mucosal immunity. It doesn't much matter generally because we don't have polio, although of course occasionally there are outbreaks of it. But we were able to move from an oral vaccine that can stop transmission to an intramuscular that's really just aimed at the severe manifestations. And so that might be what ends up, a similar analogy would be with COVID. We have a vaccine that targets the airways that might help limit transmission and ultimately maybe, get things under better control. So that's what I know more about, sort of airway approaches that I've heard a lot about. I don't know what else would be. Oh, the mouthwash question. In general, a lot of the transmission is going to be, in the airways, which is not going to be reached by the mouthwash, and so I don't think that's going to be a major player.
The one person followed up with, they already have the autoimmune disease. The suspicion is the vaccine created an autoimmune flare, and she's had it for a while now.
Well, these are things that are hard to answer over Zoom. What the vaccines do is they trigger a robust immune response, and in rare instances that could unearth something that was present and exacerbate something. So like I said earlier, in a room of zebras, you might have these types of things happening. So it's something to discuss with the doctors that know you best. Probably already are discussing that. But by and large, these are not expected results of the vaccines. By and large, these are, we've now put these vaccines into millions of people, so we know what to expect in most people. That's the best I can answer.
Thanks. So we're going to end it with a couple of questions about living in the times we are in, having to do with masks and doctor's offices, things like that. The one question is, how do I get my doctor's office staff to give me an appointment when I'm sick? They're always sending me to the urgent care. And I know with staff shortages, things are tough. I know I have faced this very issue. So how do we avoid being sent to somewhere like the urgent care or the ER where they're not going to understand what we have versus getting in to see our physician?
It's hard for me to answer on behalf of other clinics. What I try to do, I have to speak from my experience, what I try to do is have a plan with my patients, and so like, I guess the example would be, okay, we're concerned about COVID, or a viral infection, we just talked about how important it is to start these antivirals soon. So sort of have a strategy and a plan, how can we accommodate if someone's practicing in a clinic that's not going to allow them to come in, well, be in good communication with your doctor, have your doctor speak to the urgent care, have them maybe put in the prescription for the Paxlovid or whatever you're going to need. Take ownership of what's going on rather than just sort of punting it to the urgent care. Staying in the loop, good communication, and just realizing the urgent care is simply there to accommodate maybe the tests that you need to see, is this flu, is this COVID? That's really what you're asking of them. Keep it simple for them and say, look, my doctor's taking ownership. We're not dumping this on you. We just need your help. You send these tests. He's happy to talk to you, or she's happy to talk to you. We just need the help, doing this, because we know that getting these antivirals sooner is better. And keep it simple. That's generally what I try to do to get around that, and stay involved, stay connected and talking, even if it's over the phone. A lot of what we do as immunologists is, can be over the phone. It's not like I'm going to run in and do some amazing physical exam move that's going to like make the difference. It's about like knowing our patients, knowing what the immunocompromise is. How do we instruct and talk to other doctors? That can all be done by the phone with good contact and that sort of thing.
Great advice. Thank you. So this one is, you touched on it during your presentation with talking to family members about masking, vaccines, whatever. But this person is facing a situation that we hear a lot at IDF. They have asked nicely, they've presented data, they have begged, they have pleaded, but there's nothing else they can do. and the people aren't going to mask that are around them. But this person is facing another lonely Christmas by themselves if they don't take that chance and be with those people. What advice do you have for people who are facing, whether it's relatives, friends, family members, whatever, who just no matter what you've provided them with, they've gone on? What do you do to enjoy the holidays with the people that you love and you want to be with, but you also don't want to end up sick?
Right. So this is a challenging one, but an important one to talk about. So the actual answer will differ depending on every individual circumstance. There's a few points that I try to emphasize in these circumstances. Number one is the one-way masking is very effective. So even if the other people won't mask, if you mask, that's effective, and that can be quite effective. So there's one option there. You just say, look, you don't have to wear a mask. I get it. I'm immunocompromised. I'm going to wear a mask. So just deal. And that's one way you can do it. Number two is we talked about the less controversial interventions. One of is distancing and ventilation and these kinds of things and being outside. So depending on your climate, if you're Boston, maybe going outside for the holidays isn't really going to be an option. But the idea of maybe the way the room's laid out, or maybe where you sit in the room, you can control how close you are to people, how you space yourself out in the circumstance, where you're going to sit, where you're going to be. These kinds of things can make a difference, and maybe not even be noticeable to someone who's aggravated by mask wearing, and aggravated by people demanding them to get vaccinated. They're not really maybe paying attention to where the seating is and how far apart the chairs are, or these kinds of things, or whether there's a random fan running in the back room that maybe is just to kind of keep the smoke alarm from going off. That's sometimes what I tell people to say is like, oh, yeah, the smoke alarm goes off if I'm not, because people are cooking on the holidays. So you just run a fan saying, I'm just trying not to let the smoke detector go off. And by the way, what you're actually doing is ventilating the space in a really effective way. So that's things you can do that kind of sneak under the radar, that don't really, bother people that are bothered by some of the other things. So those are generally the things you can do. I wish there was an easy answer. I wish there was a magic, bullet that we could recommend. It's also knowing that you've done all the things you've done, which is all the things we've already talked about. Knowing that we do have antivirals that can be administered quickly, having good communication with your doc, and saying, look, coming out of that, having COVID tests, at home, so you can test yourself if you have symptoms and respond accordingly quickly. These are things you can do to empower yourself to liberate yourself from another, sort of depressing season. I really encourage everyone who's capable of doing it to try to do it, to try to give it a shot. I really believe that, because I think, the mental health burden of this is immense, and it's something that we need to address.
Well, thank you very, very much. Dr. Maglione, you have provided such valuable information tonight on 3 things that we are all facing and dealing with. And I can't thank you enough for volunteering the time that you took to put together your wonderful presentation and answering all these amazing questions, because they have been fabulous and very helpful.